Hello, everybody. To see you. Happy Monday. We're here today. We're lucky to be able to grab Hertzberg-Brieger in her very busy role. She's given us an hour of her precious time. And I thought it'd be great for us to be able to have an understanding of the work that she's doing, as well as get to know her a little bit more. So I wanted to just introduce her by saying that she's become actually a very dear friend of mine personally through the shul, and our kids were bat mitzvahed around the same time, so we were doing the same bat mitzvah program together, and it's kind of gone on from there, and it seems to have improved. Now the kids have left home.
We've got it right
now. So I just wanted to bring to the fore Sue's amazing mind and all the capacity that she has and the amazing work that she does, not just for our community, but for the rest of Sydney. And perhaps be able to get in on a bit of a jump start on your background and where you came from, where you were brought up, where you were born, and all of that, where you went to school with us.
Well, I was born in Sydney, and I grew up in Hurstville. And there's my dearest friend, Deborah, there. Hello, Deborah. I went to school in Hurstville, and I then went to high school in my brother, and I grew up in Hurstville, but my brother and I were both very lucky to be able to go to the local selective high school, so we didn't cost our parents a cent. And then I graduated and went into medical school. I went to University of New South Wales, and I completed medicine, and then I actually I did my internship and residency at Concord Hospital, and then I joined the general practice training program because I thought I wanted to be a GP. And so I entered that program, and I did that for about 18 months, and I realized I didn't want to be a GP. It did not suit me. So I changed my direction to emergency medicine when I realized that I had a very short attention span and really just wanted to do emergency medicine. So I trained at Royal Prince Alfred Hospital in emergency, and then I did my fellowship in emergency when I was, I think, quite pregnant with my first child. And then I got my first job as a staff specialist in emergency medicine at Westmead Hospital. I got that job when I was about 7 months pregnant, and then I did that job, and then my husband and I went to America, and we went to the Cleveland Clinic, which is a great clinic in a terrible city, and we lived there for, I think, about 18 months doing our fellowships there. David did a fellowship in interventional cardiology, and I did a fellowship in emergency medicine. And then we came back. By now we had 2 children. Our daughter was born in America. And then we came back, and then I hunted around for a job in Sydney as an emergency physician, and I started work at Prince of Wales Hospital. And then I had my 3rd child, and then I've been there ever since. So that's emergency medicine. And then shall I do my segue?
Well, I know that you wanted to skim the first few years of your life. I think there was a husband in there as well. You managed to pick up along the way.
I did pick up a husband along the way. So we were both training at Prince Alfred, and I met David at Prince Alfred Hospital. He was doing cardiology training. I did a cardiology term as an emergency trainee, and that's where we met. Oh, and he was about to embark on a PhD, I think, around the same time as we met. So it was a very busy time. I was doing my fellowship exams. He was about to do his PhD. It was a busy time.
Wow.
Yeah.
I haven't known you to be anything but busy.
No, that's true.
So it seemed like there was a time just a few years back where you thought that you might just want to add a few more strings to your bow.
Yes.
What were they?
So about 10 years ago, I decided, well, I'd always been interested in law. I thought I wanted to be a lawyer when I was in high school, but I ended up doing medicine. But I was really interested in law. So I decided that I wanted to combine law and medicine, and I wasn't sure how to do that. So I got onto the Dr. Google, and found a Masters of Health Law at the University of Sydney. And that was just a perfect fit for me. So I did a Masters of Health Law, and I loved every minute of that. And I finished that in 2011 or 12, I can't remember. And I didn't study for a year, and I got quite bored. So then I decided I was very interested in bioethics, medical ethics. So then I did a Masters of Bioethics at the University of Sydney. And then I finished that in 2015. And then I had done my Masters of Health Law with a friend of mine who worked at a place called Avant, which is a very large, or the largest medical defence organisation in Australia. And she was working for Avant. And I got a call from her in 2016 to say that they were looking for a couple of medical advisors, as the senior medical advisors were about to retire, and that this was an opportunity for me to put in my application. Well, by then I felt quite qualified for that job, because I then had these additional degrees under my belt, and also I was practicing emergency, so I was clinically relevant. So I applied, and then I've been working for Avant ever since. So I do 20 hours for Avant, and I do 20 hours in emergency at Prince of Wales, and that's my perfect combination. So I'm very lucky. It also worked out well, because around the same time as I got this job for Avant, my children were slowly, steadily leaving home. They were graduating and various things. So I was able to go from a part-time job to a full-time job, and that's what I've been doing ever since. So, yeah.
Exhausted just listening. You wore me out. In addition to these incredible roles that you've picked up along the way, you've done a fair bit of community work as well. I know that you're in charge of our medical equipment at the Shul, to make sure that we've got all the right equipment, but there are some larger roles that you've had and you've played in, I think, for the Montefiore home. What were you doing for them?
I was on the board of the Great for a while. I was on the board of Monty for a number of years. I can't remember whether it was 6 or 8, but a number of years. I'm on the Walper Hospital Foundation Board, which is a board that looks at at supporting community endeavours with a charitable foundation from the Walper. Now we've got the Great Synagogue Foundation, which is sort of in its early stages. I think that's it.
Yes. And in your spare time?
So.
you do so. I know that. So the medical ethics area, you've told me as well that you're on a committee.
Oh yeah, I'm on the Southeast Sydney Local Health District Clinical Ethics Committee. So that's the area all the way down south, Wollongong and Shoalhaven and Sutherland and St George and Prince of Wales. So that's a large health district that we're on, and I'm on a clinical ethics committee. So there's 2 types of ethics committees. There's a research ethics committee and a clinical ethics committee. I'm not on the research ethics committee because they look at, research ethics looks at the ethics involved in research and clinical trials. And I'm not on that. I'm on a clinical ethics committee, which looks at the ethics at the coalface, treating patients, deciding when there are ethical challenges with day-to-day treating of patients and things like that, then that's what we look at more or address and see if we can have any role, any contribution in those clinical ethics scenarios. And we have a clinical ethics service, and I'm on that committee. And then the Masters of Health Ethics did help in that respect, and I like that too.
So, sorry, my kitten is just hanging off a curtain over there.
Very good.
So what I was interested to know was you have this kind of juxtaposed situation where you're actually coalface frontline A&E. So in this particular time of COVID-19, you would have seen some stuff come in front of you through emergency, I would gather. I'd be interested to know like how like crazy it was, because the reports are very mixed, and also how that's played out. So that's frontline, and how you've been working in that situation, and also how that's affected you working through the insurance organisation as well, without giving too many secrets away, and also of course how that's played out in this committee that you've been working on.
Okay,
which is
Well,
kind of a separate conversation, I think.
So if you think it's been crazy, but it hasn't been. I guess I'll start there. What happened was we had a fair bit of time. We were very lucky that we had some time to prepare. I mean, that's what you want in a pandemic, is time to prepare. And what we were seeing was situations that were emerging, obviously in China, but also then in Europe, and then in America and the UK. And our government was very proactive in addressing the possibility of the situation that was arising overseas arising here. So the government took steps very early on to limit transmission and to start to initiate lockdown procedures. So whilst we were looking at everything that was happening overseas and seeing horrible scenes, particularly from Italy, that were terrifying us, and there was a huge level of anxiety and anticipatory anxiety in the hospital, in emergency, particularly in emergency and in ICU. We were very fortunate to have time to prepare, and that's exactly what we did. So the preparation being that the limitation of transmission and the lockdown meant that we didn't see the scenarios that were unfolding overseas. So in emergency, for example, all emergency departments, well, there were different stages of planning. So initially, the cases only went to one hospital, but then obviously cases emerged and that had to change. So then they went to more hospitals, and then all the emergency departments had to prepare for COVID. And the preparation involved getting COVID-specific areas. You know, you've got to have clean zones and dirty zones, which we don't call them dirty, but we'll call them hot and cold. But in any event, you had to get ready, and we did. We all got ready. And that meant a lot of changes to the structure of the emergency department, to the staffing of the department. We all had to change just minor things. For example, we all had to now wear scrubs. We all had to now wear masks. So those things emerged slowly over time, over a period of weeks, and we got ready. And for another example is that we had to, whilst we had 10 beds in the department, one next to the other, for example, we had to take one out so that there weren't two beds next to each other. There was a lot of space between the beds, so we cut our capacity to take patients. That obviously limited our capacity, but we also increased our capacity in other areas. And all of that was happening while we were getting ready and everything was unfolding overseas. So in terms of it being crazy, it wasn't, because by the time we got ready and prepared, the cases we weren't seeing large numbers of cases. In fact, it was one of the quietest periods I've known. But the problem being that people were staying away from the emergency department because of fear, probably fear of getting COVID. And so what we actually saw was a paradoxical reduction in presentations. Some departments saw up to half the usual number of presentations coming to the emergency department. And that in itself is very worrying, because where were they going? Suddenly, people weren't presenting with strokes and diabetes and heart attacks and so forth. They were staying away, and that was worrying. And they're now just starting to return, now that people are less fearful of coming to the emergency department. But I fear that some people have neglected their health for fear of coming, because you don't get COVID from coming to an emergency department, but people feared, I think, that they might. So we were really lucky in Australia. While all of this was happening, we were surging. Our capacity was surging. Our ventilator numbers almost tripled. We stopped elective surgery. That meant that we could limit resource utilization and resource allocation. We increased ICU capacity. The country's response was fantastic, so that if we do, now that the lockdown is going to be softened, we now anticipate that there will be sort of small spikes, small clusters of outbreaks, but we don't anticipate anything in the size, if you like, of what we've seen overseas. And if that does happen, we feel that we're prepared. We now have, we've significantly increased our resource allocation. So that's why it hasn't been crazy. And we've only got I think there are 6 people in intensive cares all over Australia at the moment, which is incredible. I mean, we don't have anyone in Prince of Wales ICU. We did have some, but we don't. And we've now gone back, to be honest, our department has now gone back to its pre-COVID arrangement in terms of its physicality, in terms of the allocation of the beds, the way we work. We don't no longer have a hot and cold zone because we're not seeing the numbers. And that's a blessing. We're so lucky in this country.
Yeah, that's great news. Really good news. It's nice to know that that it is safe to go to hospital and that we are well prepared and cared for. So I'm assuming that with the committee that you were working on, which would have maybe communicated with all of the other committees around the country, that all this preparation that you had to put in place would have been then filtered and fed down to the hospitals. Was that, thankfully and hopefully this won't be a decision that we have to make, but how did you make choices? How were you making choices about what, if this, then that?
Yeah, that was the fear, because we were hearing, so in Italy, I mean, I'm sure you all saw this. I don't know whether you did see the footage that was coming out of Italy. Maybe we saw it through medical social media, but I don't know so initially in Italy they were treating everyone was going to ICU. They had a mortality rate in ICU of about 90%. But then they got overwhelmed, and then they could no longer take patients to ICU. They could no longer ventilate them because they just didn't have enough ventilators, didn't have enough ICU beds. So then there were choices to be made, and those choices were the sort of choices that Scott Morrison said he never wanted to be made in Australia. And those were the choices, whether or not you limit someone's access to healthcare, limiting someone's access to an ICU bed or a ventilator. In other words, dooming them really to a very bad outcome.
Yeah,
so we know that there was a whole policy directive that we strive not to ever be in that situation. But of course, you can't, in a pandemic, when you don't plan for the best scenario, you plan for the worst scenario. So we were preparing for that eventuality. And then the committee, the ethics committee, wanted to assist in that triaging or decision making, because it shouldn't be down to one person to make any of those decisions. Those decisions should be shared, because it's a real moral burden when you have to make a decision about an outcome for a patient based on resources. We never have to make those decisions in Australia, and we don't now, but we could have. And so those sorts of preparations were essential. So we wrote a policy guideline for our area that would assist doctors who may be in that triage scenario. That would be emergency doctors and ICU doctors, to see whether to assist them if there was a situation where triage was important. So in Italy, for example, what they did was they lowered the age at which you got into ICU, and that age got very low. Obviously, people with comorbidities and with risk factors that meant that their mortality was going to be very high, they were excluded. But then, by virtue of their age alone, that's a hideous scenario. But that's what was going on in Italy, and we needed to make sure. Well, the government's policies to limit transmission, that was what was going on to prevent us from being in this situation. But we needed to empower doctors who were in that situation, if that should arise, with the decision-making tools that would help them, and to share the decision-making. So we wrote a document, we disseminated it amongst clinicians and got their buy-in, and then we parked it. And that's where we're at now.
Thank God it's parked. Long may it park. We want it to get a parking ticket or be towed away.
We wanted to get a parking ticket. Exactly. So the decisions, there weren't those sorts of the decisions. I mean, there are lots of ethical dilemmas in this pandemic, though. Not the one that hasn't arisen and please God won't arise is the decision as to whether a patient gets into ICU, onto a ventilator. But there are other decisions that we had to make. We were all, at the beginning of the pandemic, we were very, very concerned as doctors at the front line about PPE. So PPE is personal protective equipment. So that's gloves, masks, gowns, face shields, face masks. There are different types of masks, different levels of protection. I don't know whether the media was across that, but we were very concerned that we were going to run out of PPE. A lot of our PPE comes from Wuhan in China, Well, that wasn't going to happen. So there was a big fear that we were going to run out of PPE. And then there was a real moral dilemma as to whether or not our obligation to treat patients if we don't have the right PPE, what is our moral obligation to treat patients if we don't have the right PPE? And we got a lot of calls at Avant about that, because doctors were fearful that without the right PPE, they would be forced to go into a scenario where they would be exposed. It's like going to war without a gun. So we got a lot of calls about the legal and moral obligation of doctors in the event that they don't have PPE to treating patients. So that was one that was a recurring theme, both for us clinically and for Avant medico-legally. In my department, we had little cottage industry of patients and their families making face shields out of things that they sourced from Bunnings and Spotlight. That should never happen. It was because we feared we would not have enough face shields. People were talking about making their own masks. I think maybe you saw that, I don't know, on the internet as well. People getting cotton from Spotlight and a little bit of elastic around the ears, and bingo, you've got your own mask. Well, that wasn't the way it should be done at the front line. Maybe it's okay for people at home, but that's not how we should be practicing. So we had a lot of concerns about that. We've been reassured that there's adequate PPE available. But in terms of our obligation, that was a really morally challenging question for people who didn't want to put patients at risk, but by the same token, they're under no obligation to put themselves at risk. So the bottom line is that the government has an obligation to protect us, the government has an obligation to provide us with PPE, and that we are under no obligation to treat patients in the event that the government fails in their duty to protect us. And that is a sad but sad truth to it. And it hasn't happened, and hopefully it won't. But again, these are the situations that arise in the pandemic that put us into conflict, and which makes it so conflicting when we're because the way we treat patients under normal circumstances is to put the patient at the front and centre of the decision making. But when it's in a pandemic, it's completely different. It's not a patient-centred decision, it's a community-based decision or centred decision. Because if you treat a patient without PPE and then you get infected, and then you're going to infect 3 other people, and then they're going to affect another 3, and then so your duty of care to the patient has now become a failure in your duty of care to the community. Sorry, so I think I've gone sideways, but I've just been talking about the ethical dilemmas. I mean, there are more ethical dilemmas in a pandemic, and we are so lucky that none of them, it's not actually true, some of them have arisen, but the PPE one is okay at the moment. But yeah.
So you're really front and centre, because you're grassroots, like coalface in the hospital. You're on the committee making life-changing decisions on behalf of the country or for that particular area. And you're in the insurance, in that having to make decisions on behalf in a legal sense as well, and protecting people's, so you're covered across the board.
Well, so at Avant, just so I'm clear, I'm a medical advisor, I'm not a lawyer. So I don't give legal advice because I'm not a lawyer. So the legal advice comes, yeah, so I convene with the lawyers and we work together, but the legal advice I take from them, and the legal advice from them, and the legal advice from all indemnifiers, and we have a union. The doctors who work in hospitals have a union. So there was a lot of communication between the doctors and the union as to what our obligation was in the event that we didn't have sufficient and adequate PPE. So again, the standard of the general message was that, we had a duty of care, but we didn't have a duty to go in without PPE. But at Avant, my role is slightly different. I give medical advice to the lawyers and to the claims managers about cases and claims and so forth. And I defer to the lawyers for the medico-legal, the truly legal scenarios. And yeah.
Amazing. That's fascinating. And so are there any other areas that you've had to use this ethical decision making?
With COVID?
Yes.
Yes, so there are other issues with COVID, and that is that the concern that patients who should be won't get the right treatment if they come to hospital because they'll be presumed to have COVID. Now that hasn't happened either, but if you have a patient with COVID, who is confirmed, you have to put them in an isolation room with negative pressure ventilation, so that the bad air is sucked out and the good air is sucked in. Anyway, you have to put them in special isolation rooms, and that's problematic, because when you go into those isolation rooms, you have to be fully PPE'd. And so it's not the ideal way to treat patients, but it's the way it is. And then some of the treatments that you give are inherently dangerous to not the patient, but to the department itself. And we call those aerosol generating procedures. So anything that vaporizes air or spits air out that comes from the patient puts the department at risk, and that's why you've got to keep them in an isolated room. So, and there are things that we can't do. For example, we can't use a nebulizer. We can't use a machine that, a BiPAP or a CPAP machine that forces air into the lungs, because it'll aerosolize the secretions from the patient. So there are certain treatments that we can't use in COVID patients and in this pandemic. And that's been a bit limiting, because sometimes we want to reach for those treatments, but those treatments are off limits, because they actually put not the patient at risk, but they put the staff at risk. And that's what I was saying before, how the duty of care in a pandemic is so different. In a public health emergency, your duty changes from the patient being at the center of the decision to the public becoming at the center of a decision. So those are some of the moral dilemmas that you face when you have to change the way you treat patients, simply because it's a pandemic and the risk to the staff overrides the safety benefit to the patient. Yes, those are the main challenging things. And also, in the event that you need to go into an emergency, it's really important that you are gowned up, that you have got all your PPE on. You do not attend an emergency if in the situation of a COVID patient without being gowned and gloved and PPE'd. That puts everybody at risk. So there are lots of strict rules that you have to adhere to. We have to learn how to put on PPE, learn how to take it off. There's protocols about taking it off. And you have to do it preferably with a buddy who watches you, because when you take off your PPE, you put other people at risk if you spray it all across the room, etc. So all of those things, because everything that you do has implications for other people, not just for the patient. So that's why it is a completely different scenario when you're treating patients in the event of a public health crisis. Right. But we're lucky. We haven't treated that many.
Amazing. That's so interesting. I've got one more question that I was going to ask you, and then I've got a few questions that people have typed in, and obviously open it out to the floor. But as we move out of this phase and hopefully into safer times, do you think that your work, the mode of work, that how you work with patients and how you work with clients and even how you work at home is going to change going forward?
Yeah, I don't know about emergency, because I think patients will always need to come to emergency. Obviously, telehealth has taken a big, is on the rise. I don't know whether the people here have had telehealth consultations, but that's going to be big, I think. And I think that's great, but I don't think emergency medicine will change all that much, except that I think we're now going to be very focused on protecting ourselves from the risk of infection. I think that, we've always been fanatical about hand hygiene and so forth, but I think that will be a real focus. It certainly is. We have hand hygiene audits all the time, but I'm not sure that the way I practice emergency medicine will change all that much. I hope people will, for their own sake, come back to the emergency department and not leave it too late, as we've seen a lot of people doing at the moment. So no, I don't think it will change significantly in emergency medicine. I think it's going to change in Avant. I'm probably at home for the rest of the year, working from home with Avant, because I work in the city in a big office building, and I don't think they're in a hurry to get us back to work in that environment. Where our desks are too close together, etc. That's what they're saying. So I think at Avant it's going to change big time. I think we're not going to see the big office buildings being full for a long time, maybe even not till we get a vaccine. I don't know. That's a long way off.
Wow. Well, that was absolutely fascinating, and I'm sure everyone's nodding their heads to say that was very informative, and really pleased that you were able to take the time out